Good morning, this is Vernal. Can you see and hear us okay? This is Vernal. Can you see and hear us?
Yes, no.
Yes, we can.
Thank you.
Oh, I'm just whispering.
This is Salt Lake. Can you see and hear us?
Sometimes in my office where I'm in the middle, I swear to God, people say my name.
Can you guys hear us? In Bruno?
This is Salt Lake. Can you see and hear us? Oh.
I'm not sure if that changes anything, but let's.
I'm like,
This is Salt Lake. Can you see and hear us?
Bruno?
I'm only been doing it for 1 day with a week. But I'm like, I want to.
Well, I know. You have your kids here, and all of a sudden, okay, I know. Have the energy there.
Yes.
No, I know. Yeah. And you can report in here because everything else is in this.
Well, that's why I'm like, because I'm really sick. I'm trying to get those like under control because I don't want to happen this week. Like I just told my sister about this the other day. I'm like, so I'm like, so no, my desk doesn't look like desk. So we have.
I know. You do. I know what is taking over my eye.
This kid.
I know. 100%.
So there's a lot of
Okay, great. Testing.
Did our meeting encounter?
okay. I'm trying to figure out how to hide myself. Okay.
Natalie and Kelsey, can you guys hear us?
You can type in the chat box.
So I was at You don't even saying or anything like that, or like tell her who she was with, you know?
Are you?
Because when she started coming, she was like, you know what I mean?
I know she like would remote into them.
Natalie, can you hear us?
And watch them.
But I cannot hear anything.
Oh. Well, that's not what we want either.
She.
And that's what
I feel like that's let's try this. Okay, now we're testing for GoToMeeting.
Yeah, I'm
You guys hear me now?
to somebody's.
Oh, no, it's myself. Great. I never saw it.
Is it a nice one? Because
Kelsey got it broken.
A little bit shabby.
Yes, and they actually tried to look at my time.
Perfect. Thanks, Kelsey.
You know, and like actually so she could stay, and I don't know what happened.
Not a good one. Leave.
Probably won't.
You can still
Camera's
see
still on.
and
Yeah?
leave it back to us. Not like that.
Okay, Gabby did.
It's off.
Great.
And they're going to be pulling them.
Not that we didn't love looking at Erin. She does a good job. When Erin's not in front of it, then we're seeing
She
other
was really
people we do not want to be on.
that's true.
So everybody can hear.
Okay, great. I'm going to minimize my GoToMeeting.
That's awesome.
Okay.
But you're like
She screws up as much
Yeah.
Are you? This is
Crazy. Yeah.
a big space, but. And then I thought, my back is to them. My screen is right here. So patients can see it all.
so where I sit.
So. Pat, are you hot already?
I think
I
it
know
feels
exactly.
amazing.
You're happy? You might get hot, right?
I froze last time getting on my feet for half a day. That's what I see though, but I'm getting I know like a foot warmer. I just have it at my little station. I'll be like, I'll tuck him in and be like, okay.
And then we'll put the trash on this side. So the trash on this station. I'm like, okay, ready. And then I got thinking about it, and Christy actually, one of my couples said, wrote to a couple.
We're all good out there.
I have one of those in my bed.
Because I
My husband bought me that
you on the phone, and I heard what she goes to say. Just for your feet.
Yeah.
Yes. I don't know. It's bad, it's nice and warm.
It's always plugged in, but how like I could turn on. And then it stays on for 6 hours.
So, just from the insurance side of it, so we have
I was gonna
a
ask
6-month-old baby that has really complex heart issues. He's actually going into state for his line procedure.
Okay.
But he's not to goes to the feeding clinic every time. Just on from comfort. And we're with Select Med, but then in January.
So at one point,
insurance who was a kid now.
at one point,
So we had a putting everything.
is their date of birth?
No, which was good. The formula covered, and they just keep denying it. They're like, no way that I'm probably going to get it covered.
Correct, it's over the
I
counter.
didn't start that minute.
But so we would add, I have fought that battle, but I can't win that one.
Okay.
Yeah.
Okay.
And most insurances won't pay for it if it's over the counter.
So
In
you
fact,
would
I've got a
even-
baby that was just discharged yesterday on Alimentum, and that is over the counter, and I called him and said, call your doctor back and find out if there's another formula that
Except
will work for
like,
you.
so then I was
He had
there.
a cut of the so I know they want that. But just call them and see if we can. That's a waste of money, but it's the one thing that we
Yeah.
and I feel like it's worth pursuing.
Yeah. Maybe if you could talk to a feeding clinic and see if there's
If there's another
different
formula.
that they would recommend that the insurance would cover. I can't bring them
Yeah. And every insurance is a little bit different, I think. Not everyone will cover or not cover the same ones. But if they really are,
Morning. Hey, I think we're gonna go ahead and get started. Let me get the PowerPoint up here. All right. Start at the beginning. There we go. What an idea. Right. All right. Good morning. Thanks to everyone for braving the cold. We're glad you made it. Got a good turnout here, and maybe a few more people who will start coming in. So let's go ahead and take a quick look at the agenda. So we'll do some introductions, as we always do, and we want to make sure we remember that we've got some folks on GoToMeeting, as well as the folks in the room here, and we actually have a USU connection to Vernal today as well, so we'll make sure we introduce everybody. Then we're going to do our normal brainstorming session, which is when we really turn the time over to you, and if you have anything you want to share or ask of the group, get a little help, offer some new resources, update us on a case that you've mentioned before, let us know how that's going, anything that you're doing with QI or a motivational interview, we love hearing that. That's your time. And then we're excited that for the bulk of the meeting, we're actually going to be hearing a little bit about what the Utah Developmental Disabilities Council has been working on with regard to health access, particularly in the rural areas of Utah. And they are very interested in picking your brains as well with what you're aware of with regard to families you serve and their ability to access care. So I think it'll be a nice discussion. I hope a robust discussion. That's the goal for that. And then we'll wrap up. So with that in mind, let's go ahead and do our introductions. I'm Mindy Tueller, and I manage the Medical Home Portal, which we refer to a great deal in these meetings, and also facilitate these meetings and have been doing that for a while now. I think we're actually in our, if that makes any sense at all, 6th year. Starting our 6th year, which is crazy and exciting. Super good. Okay. So, Gabby, let's go ahead and make sure that we are identifying our Go meeting folks.
All right, so we have Athena Parker on the phone. Athena, can you unmute yourself and do a short introduction?
Yeah, my name is Athena, and I have newly joined the Medical Home Portal team, and am working essentially to take over what Kay was doing with updating the Utah service providers.
Cool. Athena, we're so glad to have you on the call today, and we know you'll do a fabulous job. So Athena's background is care coordination in Utah, so she's really an excellent fit, and it's wonderful to have you continuing to be a part of the family, as it were.
Then we have Kelsey Homedo on GoToMeeting. Kelsey, can you unmute yourself and do a short introduction?
Yeah, I'm Kelsey. I'm a care coordinator down in San Juan, or Blanding, for Integrated Services Program.
Hi, Kelsey.
Wonderful, thank you. Linda Stephenson, can you unmute yourself and do a short introduction, please?
Hi, I'm Linda Stevenson. I'm with Integrated Services Program, the care coordinator in Richfield.
Good, thank you so much. And Natalie Allen, can you unmute yourself? Thank you.
Yeah, I'm Natalie Allen, and I'm the nurse practitioner for the Integrated Services Program, and I go to all of the clinics that we serve.
Wonderful, thank you. Then we have a caller number 2. There's no name attached, so whoever is online, and I have not called the name, could you please?
I think it's actually me, because I'm on both my computer and the phone. This is Athena. So.
Okay, Athena. Right, thank you. Okay. And then.
Oh, great. Okay, so those are our go-to-meeting.
Yeah.
Okay, very good. So our Vernal person, I'm guessing you're George. Can you hear us, George? Are you able to introduce yourself?
Yep, I can hear you just fine.
Great. And can you tell us just a bit about yourself?
Yeah, so I'm the care coordinator in the Tri-County area, so I cover Duchesne County, Uena County, and Daggett County. And excited to be here.
Excellent. Well, welcome, and we're always pleased when one of our USG satellite rooms is able to be utilized for this. So just know that we can see you the whole time the way you can see us the whole time. So you're a little bit in the spotlight. We apologize about that, but also we can hear you. So if you have questions or comments, we look forward to hearing those. All right, and so just a quick reminder, well, actually, I need to let everybody go through it, but a reminder that for those of you here in this room in Salt Lake, we really do need to have you sign in. If you haven't signed in, please make sure you do that before you go. It's really helpful to us to know who and how many attend these meetings. So, okay, so I've introduced myself, Gabby.
So my name is Gabby Baragoshi. During the day, I'm a quality improvement specialist. At night, I'm the Medical Home Portal AD person. So. And the weekend job.
Erin.
My name's Erin Shoemaker. There we go. Sorry about that. I'm Erin Shoemaker. I am the admin assistant for the Medical Home Portal and General Pediatrics as well.
And I'm Heidi Bates. I am now with UPIC. I was a care manager at Redwood, but now I'm with UPIC.
Doing what?
Well, trying to get my feet under me, really. But right now I'm helping with the asthma QI project.
Quality improvement specialist.
Yep.
Okay, Mindy.
Butters, I'm the care coordinator at Utah Valley Pediatrics, the Provo North office.
I'm Jeanette Tingy. I'm the patient care coordinator at the Plaza office for UVP.
Plaza office,
It's in Provo. But we're moving to Vineyard in June. We're building a new office.
And I'm Tiffany. I am the care coordinator for the Timpanogos office with UVP.
I am Evelyn. I'm the care coordinator at the Cherry Tree office.
I'm Gina, and I'm the care coordinator at the American Fork office.
I'm Brooke, and I'm the care coordinator at the Saratoga Springs office.
Oh, this is fabulous.
All UVP.
Love Utah County.
Okay, Eric, you're on.
Eric Christensen, I'm the program manager with Utah Department of Health Integrated Services Program.
I'm Liz. I am a care manager at Reiner Pediatrics.
Welcome.
I'm Brad. I'm a social worker at Reiner Peds.
Wonderful. Welcome.
I'm Dora Arquena. I'm a professional relations coordinator for Shriners Hospital.
I'm Pat. I'm pediatric nurse care manager for Select Health Insurance.
I'm Becca. I'm a transitionist with the Connector Service Program at Primary Children's.
I'm Katie. I'm the care coordinator for the University Pediatric Clinic.
I'm Linnea. I work with the Medical Home Portal. I'm the services support manager, mainly working with elsewhere.
I'm care coordinator at Wasatch Pediatrics South Point.
April, I'm a care guide at Holiday South Pediatrics.
I work with April. I'm the nurse care manager.
And your name is Janelle. Okay?
Hi.
Okay.
I'm Annika, and I'm the new care coordinator at Southwest Children's Clinic.
Welcome.
Anna, and I'm the manager at the Southwest Children's Clinic.
Wonderful. Gina? Gina. Just goes by one name.
Been involved with the Medical Home Portal and UCCCN since the beginning as the parent advisor and consultant. I also am the director of Utah Family Voices and the associate director at the Utah Parent Center.
I'm Avery Pence-Hyder. I'm from the DD Council and here to talk to all of you. I'm so excited to hear all of your introductions.
Wonderful. Hi, Avery. How are you?
Thanks for having me.
You bet. You bet. Okay, well, let's go ahead and get started. Quick housekeeping. So this is to let you know there is Wi-Fi, I guess Wi-Fi if you need it. Bathrooms are kind of in the middle of the building. You can get to it from either side. We do need to end promptly at 10 or just a second before. And George, just to let you know, right at 10 o'clock, we will disappear. You will disappear while I'll go poof. So if that happens, we're not being rude. Okay. Okay, great. And then just a couple announcements. Well, the big one really is that next month is our annual learning session. If you haven't received an invite, I apologize. We're noticing that maybe we have a couple of people have fallen off our list, but we're going to go double check that today. And so that invitation will come out to ask you to RSVP so we can get a good head count for breakfast. But it's just going to be at the Intermountain in Murray at the Doty Education Center there, and the invite will have a map. And so we really look forward to seeing you all there. I think it'll be really a good meeting about social determinants of health and children and youth with special opportunities. A number of you that are here with us today will be part of our panel, so I'm excited about that. Some quick updates about the Medical Home Portal. We have updated 3 of our diagnosis modules very recently, including XXY, infantile spasms, and Rett syndrome, if that might be of value and use to you. And we've also updated some of our for parents and families pages, kind of all in the caring for your section. All right, finally, brainstorming time. So this is your time, and we really encourage you to take advantage of it because this is where we find a lot of value in these meetings is really networking and brainstorming and sharing with each other. So does anyone have a case that they'd like to bring up or a new resource? And we're happy to have the folks on GoToMeeting do that as well, even via the chat box if that's easier.
I have one.
Great.
So a couple of meetings before, we talked a little bit about transition care of an adult. And so it seems like with Heidi's help and Gabby, we're heading in the right direction to transition this kiddo, well, this young man now, not a kiddo, but I think our biggest challenge now is the family not wanting. And Annika, you talked to Dr.
And the mom.
And the mom?
Mm-hmm.
So that's been our biggest challenge, where they don't want to go. And I have 3 other cases that's the same scenario where we need to transition them. But our biggest challenge is the families not wanting to let go of the provider. And I think now it's kind of like we've done all the work we can, but it's now between the provider and the family to say, no, we really need to have you move, which the uni is an excellent. I mean, when I talked to Helen, she was telling me all the different resources that was wonderful for them. I mean, but because he's 26, he's on a waiting list that takes about a year. So
this is for the home program? Okay.
But I think something that I learned, which I'm going to share with my providers, is they don't go on the waiting list if you transition them when they have difficult cases before 22, which is something that I'm going to let them know. If this is the best care for your patient, but if we can transition them early, they don't go on this wait list. But right now, he's on a wait list for at least a year, they said.
Wow, and that is about the home program particularly.
The uni home, yeah.
Prior to age 22, they'll just transition.
Yeah.
Okay.
So that was good, and I'm going to share that with my providers, because I think they're going to help their patients that way too, and their families.
Definitely. Okay, well, glad to hear that things are moving in the right direction. Still some hurdles. Yeah. Okay. Anybody else?
I wanted to just highlight our Shriners Hospital's gait analysis. It's a motion analysis department. They were the first ones that were credentialed in the Western region. We're the only ones, I believe, in Utah. So the reason this is so important is for patients that have any issues with their ankles, their knees, their hips, and their core. It's a room about this big. It's the same technology that they use for making movies and video games. And the floor is matted, so it's when the patient's walking on it, they are getting video. And also, it can tell the doctors what muscles are triggering and which ones aren't, and that lets them know which ones they have to release or not release when they're doing surgery. They use this a lot before they have a surgery scheduled. It saves a lot of kids from having surgery because they can look and they can see, they can find other ways to actually do the treatment instead of having to go in and do it in a less invasive way. So our doctors, once they have all that information, they'll sit down with a therapist that did the study and they have all the videos, and they'll go ahead and do it, and that's how they can decide what they want to do in a surgery. So we have people come in from all over in other, primary children's uses it a lot so they can see before they're doing surgeries as well.
And Dora, do they need to be a patient at Shriners to utilize the gait?
There are actually some cases, as long as it's an orthopedic need, so muscle, bone, and joint. Okay. If they have something like that, there are a lot of it are people just coming in just to have those patients just for that appointment. As long as they have an orthopedic appointment, they can self-refer. But we do have the doctors just saying they need a gait analysis, so they can go specifically just for that.
Got it. Okay. So I will take this opportunity to say that our May meeting is going to be at Shriners. So we're really excited about that. And I think you might have an opportunity to see the gait lab. So when we've done our meetings at Shriners before, part of the meeting is the brainstorming, and then the other part will be Dora or someone else talking a little bit more specifically about the services that Shriner can offer, and then a tour. And it's pretty cool. And the gait lab is really neat. Really neat. So we're excited about that. Put that on your schedule. Okay, great. Thanks, Dora.
Thank you.
Anybody else?
All right, when did you say you were doing that?
That's in our May meeting. So
oh, okay.
The third Wednesday.
May. Okay.
May. I think it's, I don't have the date popping up in my head, but we chose May in the hopes that the youth will be out. There'll be less traffic.
May 20th.
May
20th.
May 20th. Okay, great.
It's my birthday. It's not supposed to be that loud.
Well, now we all have time. Here's visit/birthday party.
Okay, anybody else?
So just to bring home the fact that, we're kind of spoiled living in the valley, but I'm pretty sure George would appreciate being out in Vernal. I'm working with the child who was discharged yesterday, complex heart, but we've got oxygen needs from one supplier, formula and G-tube needs from another supplier, skilled nursing visits from a supplier, but from another provider. And so when these kids are going home, it's a mess trying to coordinate and get it. It's what I do for a living, but what I'm saying is the rural needs are there. Again, my eyes are continually being opened as to just how difficult it is to meet the needs of these kids.
Well, I'm sure that Avery would like to hear more about that, and we'll hear more about what the.
Well, that's right. That's what you're talking about.
That's right. Yeah.
So, Pat, was this in the Tri-County area, this kiddo, or just rural, generically?
He's in Vernal.
He is in Vernal. Okay.
Yeah, we have to go into Wyoming to get formula and his G-tube supplies. So that's the closest place. It's just really goofy.
You know, one of the other things, too, if they need some additional help up that way, we can always tag team on that if you want, George, to do some local follow-up as well. So
nice.
We can always kind of share the family once they're out, with boots on the ground and knowing resources in the area and stuff. Our local care coordinators in Vernal, Central Utah area. So Gwen, Kelsey down in San Juan, and Gwen in Moab and Price area. We can always kind of help follow up with those kids if you need it.
Nice, thank you.
Mindy, were you going to say something?
We just had we had a good experience in our office just with the motivational interviewing. I was super glad that we had two emergent cases back to back that came into our office where kiddos actually coded, and we had to do the whole CPR AED. And it was literally one, and then they were being shipped out the door, and we had another. These both kids were down for more than 3 minutes, but it was really kind of a traumatic for our staff. And as we kind of regrouped and met with everybody, I was super grateful for those motivational interviewing skills just to help people through that. And listen to that lady that came. I don't know that I would have had all that.
Wow.
So it was a good use of it. So.
Excellent.
And everybody lived.
And everybody lived.
Everybody lived.
This is good. But that's fantastic. So I'll just make a quick note that some years ago we actually had a motivational interviewing specialist come and do was it about 3 hours? It was definitely not a full day, but it was longer than a normal meeting, teaching us some MI skills. And I've thought many times about it since if we should do that again. Would people be interested in something like that? It takes a little bit of coordination. This person actually had to come into Salt Lake. She wasn't from the state. But I think the motivational interviewing field, as it were, has grown since then. So there might be more resources. It might be easier to figure something out. But it doesn't, the one thing I will say is that typically it's 2 full days that they do. So this is a much, much condensed version of that, because we know you don't have time for that necessarily. But would people be interested in that? Okay.
So Natalie writes, I would love MI training.
Okay.
And then Jack says, are you sharing your screen? I don't see anything.
Oh. Let's see.
You're sharing. I can see it.
Sorry, Chuck. I think I'm sharing. Do the other folks?
Natalie, can you see your screen?
I can see it here in Vernal.
Okay, George can see it.
What about Kelsey?
Kelsey, can you see a screen?
Yeah, I can see it.
Okay. Sorry, Chuck. Chuck, the screen says they want motivational interviewing training. Okay, well, we'll look into that. But that's really good feedback. Thank you. I'm glad to hear that things ultimately went okay. That is scary. Scary. Yeah. Sure. All right. Anybody else? Okay. Well. I did want to point out, too, that some extra goodies came in the door right before the meeting started, so if you're ready for sweets, a big thing of cookies down there.
I will say Eric's cookies if you don't have one, then you're missing out.
And I don't want to take him home, so please.
Okay, very good. Well, why don't we switch over? Oh, there's our screen about motivational interview. Let's switch over to Avery's presentation. So, Avery, I actually have your PowerPoint up here ready to go. And Avery, I will tell you that because we are using two kinds of technology here to try and connect with all the folks, that putting this on presenter mode doesn't allow something to happen. I can't quite remember what, but we can't put it in presenter mode. So I hope you'll bear with us.
That's okay.
Okay, great. And
Just
then,
don't read ahead on my slides.
right.
Then it'll spoil the fun.
Okay. Yeah. And as you can see, I've been holding this awkwardly. It does attach if you're interested. However you want to do it. They hear you better if you hold that. Okay.
Then I just can't gesticulate wildly.
We'll try it.
So I have some cards in order to kind of stay in contact with you guys. I'll tell you a little bit about who we are. And then as I'm talking, if you have questions, write them down, or you can always send me an email later, or as we get going, you may find that you have a family or somebody that you don't quite know how to solve their situation. Maybe we can help. Maybe we can't, but maybe we can connect you to somebody who can in the back or something. So I'll just get going. I get a little nervous, even though this is a small group and you all look very friendly. And the last time I did this presentation was with ACL leadership, and that was scary. And there was only 3 of them. So this is much better, but it's still, bear with me as we move through. Okay. So my name's Avery Pence-Hyder. I'm the program manager for the Utah Developmental Disabilities Council. I don't know if most of you know what that is, but what we are is we're a federal agency that works at the state level to improve the lives of people with disabilities in multiple ways. So our mission is systems change and improving access for those families and those individuals. Our purposes here today are obviously children, right? But the issues that you guys see on the ground every day impact people across the life course. So we work with people from 0 to the end of their life. Our council is made up of about 36 people. Most of those people, 60% or more, are family members, either an individual with a disability or a family member of a child with a disability or like a guardian of somebody with a disability. Noelle Taxon is kind of how I got into this, because she's on my health committee, and she connected me with Mindy and Eric, and so I'm really glad that I get to participate in your network today.
Noelle is the Bureau Director for the Children with Special Health Care Needs Bureau at the Utah Department of Health.
Thank you. Yes. She is quite the powerhouse and knows all the resources, and then she sends me to do her bidding. So that's why I'm here today instead of Noelle. Okay, so today's goal for my presentation and for our conversation is to share information between myself, the DD Council, and with you, because we know kind of what we hear from individuals, we know what we hear from providers, we know what we hear from the ACOs and people like that, but you guys are really on the ground. You know the ins and outs and the daily life of individuals that you're serving, and so we really want to work closely with you because you have that insider knowledge, that expert information that we just don't know. We want to leverage what you guys know in order to make what we're doing better. So it sounds like a lot of you work with children with disabilities or medically complex children. And we want to make you aware of the individuals in Utah who are experiencing disability and what their sort of health outcomes and barriers to care are. Can I embarrass you? Yeah. This is Livy. Livy just walked in. Do you want to introduce yourself?
Sure. My name is Livy Oseguera, and I'm the executive director. Every day and interrupting her.
So if you have questions that I can't answer, I may parlay them to Livy. And then after I kind of share our research and what we've found as we've worked on this project for the last couple of years with you, I would love to hear your thoughts on the information I've shared or other things, such as your information you shared about that child having a difficult time accessing the services that they may need. Because we're finding that across the state as well, and we want to know how we can act on that. And if you guys can share that with us, then we're better able to act or better able to support what you're doing. Okay, so I want to summarize a little bit about what I've done, what the council has done actually over the last 3 years, as we have worked through our plan. One of the things that we have been working on has been to work directly with the ACO leadership. I have a summary of this, I believe. I think I just sent it to you.
And that's on here if you want to see. So I've got this document.
Oh, great.
And I've got, there's another one. There we go.
Perfect. Okay. So back to that one. Perfect. Okay. So I've worked a little bit with the accountable care organizations, the providers that deliver Medicaid services to individuals across the state. And that's actually how I started down this road, was because I was speaking with them and they said, well, that doesn't sound like something that necessarily impacts our patients. And I knew that that wasn't necessarily true. And so it sounded like there was some disconnect between what you guys are doing and what leadership is doing. And so if we can identify where those lack of communication is, then maybe we can better send that information upward, up the chain, to those Medicaid delivery providers so that they know what it is that you're doing and the barriers you're facing, so they can work from the top down. So we can kind of cap on both ends. That's really something that I would like to see as we move forward. But that means that I need to kind of hear from you guys and also understand the barriers you're facing. And then Mindy and I have discussed potentially doing some focus groups if this is sort of the direction that you guys would like to move. We would love to hold some smaller focus groups. This is good, but maybe 5 or 6 individuals over a course of time to hear really from you about what your stories are. And the individuals such as George and Vernal and the families that you're working with in Duchesne and things like that, so that we can really hear on the ground what's going on in those individual areas. So if that's something that you would be interested in participating in, or you have families that would be interested in participating in that, please convey that to Mindy, and so then we can get those focus groups started. One other thing that we've been working with is to support, especially in Weber County, the Social Determinants of Health pilot through Intermountain. What they're doing is trying to provide a wraparound alliance network where they will refer individuals out, and then that information is then sent to that outside provider. So if someone receives insulin treatment and they don't have a fridge, then that's going to be challenging for them. So they'll refer them to somebody who can help them get a fridge, and then they actually send that information onto that resource so that that resource can follow up on the back end. So they have that sort of wraparound care. They hadn't really been too aware, or it wasn't really on their radar to include individuals with disabilities, and so we've asked them to include a question specifically about disability services. That sounds like something that medically complex kids or kids with extra needs may need. And so hopefully we can get at that root of those extra services, because now the question should state, have they gone without medical or disability services in the past 6 months? And then some of our other access efforts that we've done over the last couple of years, we've been trying to work with the Social Determinants of Health Committee and Council at 211 United Way in Salt Lake. And they have a group that's really trying to help root out some of those barriers to care and barriers to improving lives. We hope this year to further our collaboration with Huntsman Cancer Institute, because they recently started a Social Determinants of Health program as well, the Hope Center. And we don't know what that will look like, but as these conversations move forward, we hope that we'll have a better formulation of those ideas. And then we've been speaking with providers and leadership at the top of healthcare, including the accountable care organization leadership. The Department of Health's been really responsive, which has been really great. The Department of Health has a council called the UDAC, which is the Disability Advisory Committee, and they've been very receptive to trying to close these health gaps as well. We've worked with UBIC. Did you say you were on UBIC? Somebody here was from UBIC. They've been trying to support some of the systems change efforts that we do because they work directly with individuals, especially who receive waiver services. So they have kind of helped us identify a lot of those gaps and barriers for waiver recipients. So if you have the chance to work with somebody there, that's a really great connection for us to make if that's something that you guys work on.
Avery, I think our acronyms are just really similar.
Oh, okay.
So these guys work for UPIC.
UPIC.
So can you tell us what UPIC
UBIC,
is?
Utah Brain Injury Council.
Okay.
It is for waiver recipients who receive services for some kind of traumatic brain injury. And I believe the recipients are across the life spectrum. So there's kids, and then there's adults. And the UBIC, the council, is support coordinators and care coordinators who serve those individuals who receive waiver services. So they're not necessarily the families that sit on that council. They're the people who work directly with the families, similar to you. Thank you for clarifying.
Sure.
And then we've also worked with the local health department in the 4 identified counties we'll cover. But I know that there are other counties that experience gaps in services and barriers to care in the same way. We've only just spoken with the 4 at this point. And I'll go over that in a moment. And then in 2 cases, we've had individuals from our council present to the commission. So in Paiute and Beaver counties, we've taken our information to those commissioners at the legislative, sort of local government level to share our findings. And time and time again, they kind of refer us back to the people like you who work on the ground, that they feel like you guys are the sort of front line and you guys are where we're going to be able to make the most change. We don't necessarily support that idea. We think that it should come in both directions. But if there's anything that we can do to support you in those counties, then that's why we're here. And one last thing. I know Mindy said that she already hawked this for me, but we're holding a series of public comment meetings across the state in order to identify really what our families and individuals need and what the disability community kind of wants to hear from us and see us work on over the next 5 years. I have 20, and I thought that I counted 20, and then like 3 more people showed up. So I'll leave those here if you decide that you want to go or share or participate or fill out the online version of that public comment meeting. That's also an option. We really want to hear from people who work directly with our community so that we can make sure that our efforts align with what the community wants. That's the purpose of those meetings.
Can that sheet be on our resources for today?
Yeah, I'll send that out.
Yeah, and let's see. This one. If you get your scanner out and QR it, it'll show up on your phone and you can fill out the survey that way as well. So either just you can take a flyer. It's also on our webpage, on our Facebook. If you don't follow us on Facebook, please do, because we share a lot of our resources through social media. I'm in charge of Facebook, so I have to plug that. The more followers I get, the more money I get. Right, Libby? Okay. I wanted to talk to, before I go on to that, some of our legislative efforts that are going on right now that may impact some of the families you're working with. And that's a lot of where our efforts are. So we try to advocate at the legislative level and at local government level as well to improve the system, right? We can work within the system as much as possible, but if the system doesn't fix, then we're just pulling people out of the river. So we have been trying to work this year with the legislature to improve the lives of people with disabilities. In particular, there are 3 bills. I don't have the number for the 3rd one, even though I got numbered yesterday. One of them is delegation. So an individual who has a complex medical need may need nursing level of care. And in those cases, Medicaid will generally only pay if a nurse does them, right? Because it's a nurse-required task, such as a G-tube feeding or cleaning out a trach or something like that. This bill would allow nurses to delegate to trained home health or personal care attendant, somebody like that. And then the family is able to kind of stretch their dollars a little further because now home health is doing it at $15 an hour instead of a nurse at $70. And that means that they can do it more frequently and make their Medicaid dollars go further. So we are a big fan of this bill. It went through committee yesterday and should go to the House floor in the next couple of days. If that's something that your families, the people that you work with, are impacted by and you would like more information, feel free to email me. We always encourage families to go and talk with their lawmaker, but also with the other lawmakers who may be deciding on this bill, whether they support it or don't, so that we can make sure that we're creating good policy. So if you have a family that would be willing to speak to this bill, please reach out to me so that we can put them in contact with the right people or their own lawmaker, and we can support them with those visits in order to support the bill that went through yesterday. So that's House Bill 274. And then the other one is limited supports waiver legislation. I heard somebody mention a wait list. So we deal with wait lists all the time. And there's a really long wait list right now for people to receive waiver services. It's based on most critical needs. So currently there's about 3,000 people waiting because they only have enough spots on the waiver for those with the most critical needs. So if you just need respite, if you just need, a home health once a day or some kind of job support, you may be waiting for a very long time. So the Senate Bill 44 was introduced in order to pull some of the people who don't have critical need off the wait list and provide them those limited supports, such as respite and some limited community-based support. So, yeah.
I don't want to correct you, but it doesn't remove you from the wait list.
Right.
You don't lose your place in line. You just get some services to help
While you're waiting.
While you wait.
Yeah, thank you. No, that's good. We really want to, what we see is we see families entering into crisis, right? So they sit and they wait forever, and then they end up in crisis mode because they haven't received the services that they need. And now they do have most critical need, and so now they do get bumped up. But we don't want families to have to get to that point before they get the care that they need. So this bill addresses some of those issues. It preserves their position based on when they applied and their need, but allows them to avoid crisis in whatever form that means for them.
What are those waiting list services? I know historically, like some respite care has kind of been the big piece there. What other types of services are they looking at helping to provide while they're on the wait list?
They haven't identified what those services will be, but just like Avery mentioned, supported employment, behavioral supports, respite, basically anything that's not residential or what was the other? Anyway, they're still identifying it, but those are some of the things. Yeah.
Right. The initial bill said...
Just add in real quick, because I know that we talk about waivers a lot in here, so
Yeah.
I just want to clarify when she's talking about this specific waiver, they're talking about the community supports waiver through the Division of Services for People with Disabilities. So it doesn't really affect our medically complex children's waiver or the technology dependent waiver. So it does get confusing when we start talking waivers and access and such, but this one, from a parent's perspective, because many of us that have the younger kids, and we definitely need the rest of it, is the access to Medicaid as well. That helps.
Right, they automatically get a Medicaid card, is that right? So anybody who would be qualified under this new limited supports waiver would automatically qualify for Medicaid as well. So they would get the medical care that they need, plus the home and community-based supports that they need to stay in that sweet spot where they still need services, but they're not going to jump off a cliff, right? Because we've heard from the Parent Center that we see time and time again families that are just at their wits' end. They just can't do it anymore, and this bill is going to try and pull some of those people back so that they don't feel like they're at the cliff. So we really like the language of that bill, and again, if you have families that can benefit from those kinds of changes, please send them our way. And we would be happy to support them.
So that's not necessarily just meeting the rural definition, correct? I mean, is this something that's available out there? The reason why I ask is I have a set of twins that came home a week apart, and mom can't stay up all night and meet the needs and take care of them and go to work.
Mm-hmm.
So I've given her some resources, but is this something that you guys could help with?
Yeah, I think so. We can always we can introduce you to the people who might be able to answer her questions. And then if there's a policy change, we are always happy to support policy efforts and advocate for families like that. So would you reach out to me and we can chat with that family and see what we can do? All right. So in 2015, the UDDC commissioned some research through Utah State to identify gaps in services for people with healthcare needs across the state, particularly those with disabilities. So as we go through, these items that we cover affect all Utahns, but they are especially crucial for those experiencing a disability, because if individuals without disabilities are experiencing these healthcare barriers, they're magnified for people with disabilities who may have no specialists or a lack of treatment in their county. So the research was conducted over a year, 2017. It was finished in October of 18. So it's a little bit, I don't want to say outdated, because it's good, solid research, but it gives us a good starting point, even though it may be a little different today. So right after this came out, one of the counties actually added a primary care physician. So one of the counties reports that there are none, but now there's at least one in the area, which is good. And then I will discuss a little bit about the Department of Health's Disability and Health Program report from 2017, so around the same time period, that just talks about the health outcomes for individuals experiencing disability in Utah. And then part of understanding sort of the environment that these barriers are in, we worked with the local health departments to study their community health assessments that talks broadly about health outcomes in each county, and then extrapolated from there how that kind of moves over into individuals with disabilities. So I have a summary. I have 20. If you guys, those sitting close together, want to share one, everything that's on this is also on my presentation. But I like to have visuals to follow along. We'll just take one and pass those around. And I can also send the full report to anybody who needs it. It's also on our website, which I will also pass out. So it's at the very top on the link that's there, and then that's the one from the Department of Health. And then if you go to the UDDC website, the health disparity research, the full report is on our website. Can I show them?
Oh, sure, of course.
Okay. So you just UDDC dot. Oops. You came to UCCCN Council.org. And then it's here under resources, and it's right here. So if you need the full report from 2018, it's listed on our website. So the CPD identified, Utah State University's Center for Persons with Disability is the agency that conducted this research. So you'll see them referred through the report as CPD, which is the Center for Persons with Disabilities. So they identified 5 counties. One was the county with the best access to services, and then the 4 counties with the least access to services. And Davis County was listed as the best, the sort of standard county with some of the smaller gaps for services. The other 4 are Rich, which is Bear Lake area, Beaver, Central Utah, Paiute, Eastern Utah, and Emory. the San Juan area. So very rural, which makes sense that they would have the least access. So the county-based research findings found that a lot of, across the board, not just people with disabilities, a lot of the people accessing barriers to care are low-income, aging adults, and lack insurance in any form. Paiute and Rich both lack primary care physicians. I believe since then, Rich has added a primary care. So they have one PCP in the county. Beaver has 4 and Emory has 2. And then dental providers follow the state provider to patient ratio trend, which I believe was 1 to 2. And then in Emory, it's actually 1 and 4. So for every 4 individuals, there's 1 dentist, I believe, or 1 sort of provider. And then mental health provider to patient ratio in these counties was half of the state average. So it takes twice as long to get in, and there are fewer providers. And then education as a whole, from high school through college, was a major barrier to care, including education about access, about their condition, and about how to use the service and system to their advantage. And then the Disability and Health Program Report, which is the top link that I handed out on that sheet. Nearly 1 in 5 Utahns are living with a disability. I think that number actually has gone up, so now it's considered 1 in 4 through the CDC. And these are across the board. So mobility-related intellectual disabilities that impact independence, vision-related disabilities, and disabilities that impact self-care. And then also the report found that people with disabilities are more likely to engage in unhealthy behaviors, including tobacco use, sedentary lifestyles. They are more likely to experience chronic health conditions like diabetes and obesity. So Bear River Health Department, which encompasses Rich County, found that the major concerns were diabetes, depression, and substance abuse, and almost 14% of people had a recent mental health issue. In central Utah, which was Beaver, I think, they say cost is a barrier to care. It's very expensive to receive care out there, especially if you don't have insurance. Heart disease, cancer, and diabetes are the main causes of death in those areas. And similar to Rich County, diabetes, depression, and poor mental health are the areas with the most opportunity to improve. I want to see. Sorry. Just a minute. So the Central Utah Health Department includes Paiute County. And then in southwest Utah, which is Beaver County, again, like I mentioned before, the lack of education about healthy behavior and preventive care was a concern for residents. So education in a formal sense was limiting because of work and access to insurance and things like that, but also personal education about their conditions or just healthy lifestyles also created a sort of internal informal barrier to care. And then, like with the other 2 counties, diabetes and prediabetes was a concern amongst residents. And then southeast Utah, which is Emory County, 83% of respondents said that social and emotional wellness. So in each county, mental health was a big indicator of like a lack of access. They didn't feel that they either had somebody they could speak with, or they didn't feel that it was worth their time to pursue. Some people have reported in Paiute County that they were concerned about stigma, that their communities are really small, 1,500, 2,000 people, and if somebody sees you coming out of a counselor's office, they may share that information with their neighbors, and it just compounds. So that concern over stigma was a barrier to mental health services that we noticed as well. In terms of what we're trying to do, I know this is questions, but In terms of what we're trying to do is we really want to take this information and share it with you, but we don't feel that that's the end. So it's not just enough to tell you this is what's going on in these counties. It's not enough to identify these barriers. We really want to take the information that we have and the information that you have on the ground and really mobilize that. We want to know what we need to do next. How do we really root out these barriers and gaps in services from our perspective and from your perspective, and how do we really get that train moving so that we can really act on this information? So moving forward, we're working on our next 5-year plan, and we really want to know what activities we should be working on in order to really get to those issues and try and solve some of those systemic problems. So now I'll turn it over to questions with that in mind about what we can do moving forward as a group and as the council. Do you guys have any questions for me or thoughts about the research?
So as we know, statewide, there is just a dearth of behavioral health providers, no matter what sector you're looking at, whether you're looking at Medicaid carve-out in each of those health districts, or whether you're looking at just private providers out there. What are the thoughts, aside from, providers hanging a shingle in a community and actually providing those services? What other alternatives are being explored? Maybe is telehealth a consideration for some of that? I mean, I don't know how applicable or appropriate it is in every case, but
yeah,
for certain follow-ups or things like that.
Definitely. So we're excited by some of the telehealth work that's being done across the state. The state did a pilot last year. They fully funded it in the 2017 session, I think. So that's been going through the 2018 and 2019 years. The Department of Substance Abuse and Mental Health has taken that pilot and tried to roll that out in local areas. And so DSAMA is working directly with Bear River Health Department to implement a telehealth for mental health care in terms of accessing counselors and crisis in those rural areas. The biggest thing that we've seen as we've explored that is infrastructure. Right? If you don't have Wi-Fi, you have a really crappy cell phone connection, how are you going to access telehealth care? It's a great idea in thought, but in action it may not work. So we know that Paiute County has tried to use some of their intergenerational poverty grants to improve infrastructure in order to create networks that people can access those mental health services through telehealth. We talked to Paiute County about trying to support some kind of using the structures that are already there, like the high school. The high school has excellent access to internet. So can we find a way to move families from their residence into the high school to receive that kind of telehealth? That's been really slow going, but that interest is there. But I know that Bear River Health Department in Rich, Logan, Cache counties areas they have their own mental health telehealth pilot that they've been rolling out. So we know that it can work. The counties just kind of have to get on board with it as well.
We've been exploring it as well. We provide some limited diagnostic and evaluative clinics for local health districts. And we've been looking at pieces that we can try to provide via telehealth and getting families to actually the local health department, possibly, where they might have a internet connection that's slightly more reliable.
So maybe we can explore that a little bit further and see what we can do to access. And like I said, that stigma is really a big barrier for people taking advantage of the mental health services that may exist. So Paiute has a counseling center in the county offices. It's in the same building as the county, the superintendent of the schools, and the mental health and substance abuse. They're all in the same building, but people don't want to take advantage because they're concerned about their neighbors. So we feel that telehealth for mental health is especially good because people can do it from the comfort of their own home. I know that the VA has tried to do some things like that with veterans in mental health issues and trying to get at them where they are, which is in their homes, and trying to overcome the stigma of counseling through a phone service is still a legitimate form of mental health care. So there are models out there that have been successful. It's a matter of getting the local individuals to kind of sign on to them and implement them. I know also that the ACOs, the Accountable Care Organizations, that's a big interest for them as well, because they kind of got caught up in an audit where that was the biggest issue, was that the ACOs were not serving enough mental health care. They weren't allowing Medicaid patients to reimburse for mental health, even though that's a Medicaid rule. And so that's a big issue for the ACOs. So maybe there's a connection between the Medicaid providers, you guys, and what the local health departments are doing. Any other questions for me? Curveballs?
I'm wondering, I'm glad Gina said about the waiver, because I was thinking a whole different waiver. So how do people get hooked into that waiver? Like when you're talking about the 3,000 people on it, is that like they go through DSPD or what?
Yeah, I don't know exactly the process. Maybe Libby can talk to that process a little bit, but that is administered through DSPD. It's a Medicaid waiver administered through DSPD. Do you have any?
Again, like the services that will be available on the limited supports waiver, the intake process is also being developed. So they're not quite sure how people will be able to come into that waiver.
The new one, the new waiver.
Right. There are a number of things they're exploring. I believe that they'll have, what is it, 700?
Yeah, it was like between 600 and 900 people that they wanted to
they might be able
pull
to
up.
serve.
Yeah.
And how long you've been waiting might be a factor, how long, so there's a number of things that they're exploring. And again, that intake process hasn't been decided yet.
And is the thought that it would begin state fiscal year, this new one, July 1st? Is that what kind of the thoughts are?
I haven't seen anything in the language that would say that, and they have to find the funding to do so, because I don't know that the current bill as it's written includes an appropriation. They hoped that it would. I think they hoped that they might get the $500,000 that they asked for, but there's no guarantee that that money will come. So what this bill will do is allow DSPD to look for that money and send it to you guys, and then to Medicaid and Department of Health in order to access those services. So I don't necessarily know that it will start July 1st if the money's not there, but it will at least allow them to start the wheels to get that waiver moving.
What's the DSPD waiver? People who applied for disability got on the waiver to wait for Medicaid or services. That's the wait list you're talking about?
Right. That's
3,000 people.
There's like 3,600 people currently on it. They all qualify for some kind of disability service through DSPD. I don't necessarily know if they have to have disability through Social Security or anything like that, but they have to have a qualifying disability. And if they're not in that most critical need category, then they get put on this wait list. And their position on the wait list can change at any time depending on who else applies after them. So I talked to somebody who was number 75, and then she got bumped to number 350, and then she got bumped back up to being in the 20s, and now she's down close to 1,000. And they regularly audit the wait list, and so that data can change based on who applies after you. Any other questions? The wait list is like something we hear about every single day, because it is something that we really... That is the biggest barrier to people with disabilities who need those critical services. That's the biggest barrier. And then once they get waiver services, or they are qualified for them, if they live in an area like this, that's great. They qualify, but where are they going to go? So a lot of the families that we work with who are down in Paiute or in Beaver, they actually drive all the way to Salt Lake, and they'll go to Primary Children's to get their services. Some of the families we've heard from will say, I go up and my daughter gets all of her stuff done, and we spend 2 days, and then we drive home. So distance, time, money. If you have 3 days you can take off of work to go get your child's teeth cleaned, then that's great. But if you don't, then you're just kind of left in the county without any services.
Me again, shocker. Sorry, guys, I'm monopolizing this. I just know that with the kids we see, we do probably 75% of the kids we see are suspected to have ASD or have been diagnosed with ASD. So, we're excited to be able to provide that diagnostic interview, the testing, all the rest of it, and providing a diagnosis. But once that kid has a diagnosis and they live in Timbuktu, now what? So, I mean, that's the other piece that we're finding is how do you get ABA therapy? How do you get other supportive services? Got that diagnosis, and that might help you in school with some educational accommodation. You know, maybe your 504 or IEP or something, but doesn't necessarily give you services unless you're willing or able to drive. And I know, again, a lot of organizations are trying really hard to put in some sort of like a telehealth component to try to be able to be supportive for those families as, you know, some sort of an alternative. But ultimately, you know, what do you offer these families?
Yeah, definitely. We see that. We see that, you know, they try to implement things like they'll train the parents on occupational therapy and some of those tricks of the trade that they can take home with them and implement at home because they can't get that direct care all the time. But that's kind of a workaround. It's not a solution. We have worked with TSAMA and a couple other human service agencies to try and provide dual diagnosis for families or for clinicians down in the rural areas. So there's one we did in Price. Is that where the other training was at, in Price?
Price is coming. It's in April.
In St. George.
St. George, just like this week or last week.
Yeah, to try and pull all of the clinicians in the area into those centers and train them about how to serve the mental health needs of individuals experiencing a disability. Because the co-occurrence of a mental health condition and a disability is pretty high, but clinicians may not know how to treat it, especially in rural areas. So they will just say, you know, you don't have anxiety, you just have autism, and send them on their way. So how do we train providers in the area to recognize this is symptomatic of this and this is symptomatic of this, and provide that complete care and not just put a Band-Aid on it and send them home? So we've seen that, and especially with mental health. And then mental health for families too, right? So you may have a child with a disability and you're living with that stress. Are we doing enough to provide support for the parents? And I think that's some of this bill, this limited supports would provide, such as respite, but we know that there are still gaps to accessing that kind of care and support at the family level for these families. So we love the idea of a telehealth. It's just a matter of how do you get people to sign on and take advantage and build the infrastructure. The other thing that we've heard is how do you bring in a doctor when there's no hospital down there? You know, one of the areas, Sevier County, has their big hospital, and that's who Intermountain worked with the local health department to conduct their community health assessment. But that's the closest hospital for some people for 150 miles. And if you can't get a doctor to go out there and work, then how do you treat the individuals who live an hour and a half away from Sevier County? There's a bill that was introduced this year, I don't know its current status, that would provide scholarships to families, or to medical students. So if a medical student comes from a rural area or lives in the area and goes to medical school at the U and then agrees to go work in a rural area, then they'll forgive a portion of their loans. So that's trying to get at that. You know, there's not a lot of money to be made, so they're trying to get at that economical side of bringing a doctor out, and then to get the students to sign up for that, if the bill passes, would be the next hurdle.
So, in regards to payments and insurance companies for practices, so does the practice actually do they get reimbursed in regards to a telemedicine appointment if you were to start, or is it something that you have to go revisit your contract to make sure that, is there anything special?
No, I think my understanding of the Medicaid reimbursement is that they can reimburse it just as they would for any other sort of care, even though it's telehealth, whether it's mental health or like a clinician on the line, you know, on the other side of the iPad, that Medicaid will still reimburse at the same rate that they would a person-to-person visit. That's my understanding.
Right now, the Utah Medical Association is kind of lobbying and on the Hill looking at a telehealth parity sort of a piece to try to get that, because even though they talk about reimbursement being similar, there still isn't kind of an equitable way of doing that. Plus, you also oftentimes with telehealth, you have the delivering physician who's able to bill for it, but you also have a paraprofessional or someone on the other end who basically eats the cost.
Mm-hmm.
They've got the patient right there in their facility, their office, whatever, and it's just kind of a freebie, if you will, so that the patient can have that connection with the provider who's on this end, doing the service. So I think they're trying to look at trying to make that a little more equitable so that you can bill on both ends of the telehealth camera.
And that's going on now?
Utah Medical Association is kind of pushing that right now. I've not followed that as much as I should have, but they're kind of lobbying and kind of talking that. I think there's some sort of a bill they're trying to sponsor or have sponsored right now.
Thanks. Now you're on.
So I have a comment. This is Natalie Allen. Sorry, I'm a provider, and I just want to weigh in on some of your rural providers and why aren't you talked about the dual diagnosis conference that you provide for people, but the problem is in some of these practices they only have 1 or 2 or 3 patients maybe, and so they never become an expert at dealing with the medications and the things that go along with having a dual diagnosis. And I feel like telehealth is great, but yet if the provider can never be proficient, we need to provide support for the providers, because most of the ones I talk to, they want to take care of these families, but they just don't have the expertise. They don't do it often enough to feel comfortable. And so looking at some sort of telehealth, but it's really more of support for the providers. I don't know how that would work, but it needs to be somebody that has experience with people with disabilities. I know there are some lines at the University of Utah for providers to call in, but I don't know that they're specifically for people with disabilities. I don't know. It's just my thought.
No, thank you. That's really thoughtful. As a provider, what would that support? Could you tell me what you think that might look like, or where you find the biggest challenge?
Well, I have kids that are referred, so our clinic is very small and we're not able to see very many patients when we travel around to rural clinics. So what I get is providers referring kids to me. Maybe they have ASD and they need some support to try, let's say, ADHD medications, but because the child has a dual diagnosis, they're uncomfortable with even starting some of the basic ADHD meds because kids don't respond necessarily typical of a child without ASD, and they just don't have the experience. So they send them to me, but I don't provide primary care down there. And so the kids get stuck in this, they come see me, I try to start medication, and they go back to their providers. And just like any other child, in a year, they need to have things readjusted. And again, they're back to the same place. It's hard. And I feel like the providers in the rural areas really want to help families. They don't want to send them away, but they just don't feel confident. And I don't know how to bridge that gap, but I don't know how.
Thank you. I appreciate that. I don't have an answer, but I'd be happy to see what we can do to continue that conversation.
Yeah, I'm very interested in continuing the conversation. I don't know what group or council I should volunteer for, but I feel like I have a lot to share because I've been out there in the rural areas as a provider. I talk to providers, and I would love to sit around a table with someone. So put me on the list.
Okay. Can I get her information from you, Mindy?
Yes, I believe she's given me permission to give you her contact information.
Or you can send mine to her if that works better.
Okay, we'll do it.
I know that the uni at the university is planning a more robust approach to supporting providers and providing care for mental health conditions. And I can't remember exactly what the status of that is, but it had a program called GATE that was electronic for a number of years. It has never been used robustly, but this is aimed to be much more user-friendly. And so I will try to get some information about that and then get that out to the group.
Thank you.
Thanks, Chad.
I think I have some information that is too for our mental health QI project, so I will definitely give it to you. Yes.
Great. So I have a question for all of you. when you identify concerns like this, how does your group sort of act on those? Do you all just take them back to your sort of requisite locations and try and implement it where you are? Do you share? How does that work for your group? If we come up with some kind of solution, or you have ideas and he has ideas, how do you all implement that kind of at your level?
So if there's a system level change, and we can get the word out, and we can really help people know how to access it, then we often hear really positive reports in subsequent meetings. This is working, and people start adopting it, and it becomes more widespread. I think a lot of times what happens with this group is they're sharing the back alley. It's not back alley, but
the workaround.
The workaround,
right?
Things, and that's often what these scrappy folks on the ground are forced to do, because there hasn't been the change at the state level, at the county level, at the what have you level. I think that this would be a fantastic group, particularly those who are working in those rural areas directly, to let you hear more specifics about the barriers, and maybe some ideas that they would have. But these guys are tremendously overworked, and the idea that they'd be able to sort of on their own go out there and make some changes is probably not in their wheelhouse, because of their roles and their tasks and task levels. I know that when we do hear about something that's positive and we hear that it's worked for one person, that will get picked up quickly. So this is a great place for a new opportunity, a new resource to kind of spread like wildfire, for sure.
Okay. Yeah, it sounded like you had a barrier, and then you found a way kind of around that, and that worked really well for you.
It's going there. It's getting there. Yeah, I'm excited.
And then so everybody else kind of takes what you learned and implements that in your practice. That's how that works.
Except there's always that caveat that whenever something is fantastic, it quickly gets consumed, right, to its limit. So
I see.
It's very rare that you'll have a resource that is open and not at capacity or not close to capacity, right? So we're always bumping up against those limits. Always.
Okay. Well, I think what I guess I envision is, because you guys know those workarounds, you guys know what's working, what's not working, where those barriers are, and we don't necessarily know, right? Because we're not on the ground. We want to be able to take what you guys know is working and present that as a solution at upper levels and advocate for those changes, because if it's working for you, can we codify that? Can we put that into the system and change the system to make that work on a legitimate basis? Not that your roots are illegitimate, just that how can we make that into the system? Work that into the process so that it's not just a workaround. It is a critical part of successfully closing those barriers and closing those gaps. So I would love to do those focus groups with you guys if you're interested, or as you're working through things, especially as you see in terms of gaps in services and serving children with disabilities. If those come my way, then I can try and work those in. But I think the best way to start is with focus groups and conversations and phone calls, and go the old school listserv way, and we'll just all share information.
Just an observation when I worked with the rural areas for like hospice groups, and that one of the things that we saw is not only getting the services out there to even get them home, but some individuals who are on a more stable basis coming out of skilled nursings, especially in some of the tribal groups, they'll have one wheelchair for an entire area. And so you tell a patient, go home, we'll get you a little, orders for all of these things, and then they have to wait until someone's not using that wheelchair for 3 months. And so for those 3 months, the home health can't work with them, the PTs can't work with them, because they literally don't have this one, or crutches. They'll have two crutches for 500 people, in this area. And so I don't know if that helps, but just that was one of the biggest barriers I saw, is no matter the education we provided coming out, no matter the orders that were given, the doctors are ready to follow up, they get out there and there's no physical equipment.
Yeah.
have one home health nurse that's seeing 400 patients in a valley with her company, and they're coming in and out of Salt Lake. So it's just those. It wasn't just the provider; it was the whole down the line.
Okay.
A lot of them weren't even in those counties; they're coming from out of other counties to come in and try to see them.
Okay. While you're speaking, I'm thinking about. I know that there are resources that exist through places like 211 that might be able to help find some kind of free service or reimbursement program or something, or help, Medicaid can fill that gap or something, so that they don't go home without that equipment. The question is, how do you link everybody together, especially before that person goes home?
Right. We found there was one that would donate equipment, but again, you have to catch them before they leave the hospital, and if they go home and they don't have that equipment, maybe they didn't realize they need it, and then they get home.
Yeah.
It's like, we can fax an order for a wheelchair, but there's no wheelchairs, and they can't just go yank it from the other patient's house, and so it just becomes one of those. How do we get it to them?
Okay, thank you. I appreciate that.
Put in a plug then for Family Voices and integrated services. Is if you can get the family to get to us, we work with all of the. I don't want to say underground, but there are some underground resources to help in these cases where, families are helping other families get that until we can work through all the red tape and such. And we work very closely with the connector services at Primary Children's to, if there's families that are going without formulas and all of that, we're trying to meet that immediate need and find those. It doesn't always work, but we also have really good relationships with foundations across the country that help as well for some of those needs, and to kind of backtrack, because like you said, once they go home, families are like, who do I call and such, and so if you call the DD Council or Utah Parent Center, you'll get to Family Voices, and that's kind of what our project does with children with special health care needs and integrated services.
I was going to say, I didn't catch what was your first name?
No, April.
April. So at Shriners Hospital, it's driven 100% by the mission, which is patient first. So they have the wheelchair department and therapy department that has all those things. So if the family does not have insurance, they are taken care of as if they still have insurance. They have all the equipment, and they build those chairs to fit to the patient.
So they need to physically come out here to pick up, because that's what we saw. Is these families don't have cars necessarily. They don't have the money to come back out here for just.
They're 4 or 5 hours away.
Service, and so they're just. Never mind, it's fine.
It is complicated, but they do have assistance for them to travel if they have a way to have someone drive them. They do have assistance. So we do see patients from not only locally rural areas, but all surrounding states. So the Shriners is one of the biggest things. We don't want children to go without the equipment they need, so they even provide assistance for them to travel.
Eric,
I was going to say, it kind of brings up an interesting thought as well, though, just transportation in general. It's very cavalier when you live along the Wasatch Front, your car that's within 5 years old and drive wherever you'd like to go. We have a lot of folks who are in, 20, 30-year-old cars that get 10 miles per gallon. You might be on Medicaid and you can get travel reimbursement, but the reimbursement is horrendous. What they'll reimburse you per mile, and it probably doesn't even get you out of, Paiute County on what they're going to reimburse you. And then being able to front that money up front and then wait for that to go onto that EBT card back from services is problematic. So I would just say generically it would be really awesome if the system could come up with some sort of a transportation assistance, way to try to help folks get to where they need to be on the front end. And I'm not talking just Medicaid, because you have a lot of working poor who may have very limited insurance, don't qualify for Medicaid, but still don't have means to travel to the Wasatch Front or wherever.
I will plug 211 here. I don't work for 211, but I feel like I do sometimes. They have a really cool medical service where if you are traveling for any health-related purpose, I think it's in the Wasatch Front, so it doesn't get to those rural needs, but they will they will do, I think it's through Lyft. They will provide a free Lyft transit for you, either to or from your health visit, whether that's mental health, physical health, going to the pharmacy to get your insulin filled. 2-in-1 will cover that ride for you.
It's also for any social services, going to WIC,
Yes,
food banks,
heat, anything like that.
Medicaid office, whatever.
Part of that wraparound, right? So if you are trying to resolve your mental health crisis, but your power's turned off, Lyft will pick you up and take you to get your power turned back on. So that's a really cool service. We worked with UTA this last year to sponsor to sort of start up the VIA program, which is employment centered, but it's first and last mile, and that is rolling out in the South Salt Lake area, still in a pilot, where you pay your $250, which is a bus fare, and they will drive you a mile to the closest fixed route stop. So if you live, in
Was this South Jordan, Harriman area, like way out south, if I remember correctly? Saw that.
So it's like if you want to take the train, but you live too far to use your wheelchair to get to the train, they will pick you up in a wheelchair accessible vehicle and drive you to the train stop. And it costs the same amount that it would cost you to ride tracks. And that is part of your fare. So it just transfers just like if you were to connect on a bus. So that's supposed to be employment related, but it's still there for those who may need it in your group. So there are health services in that transit area, and then there's employment as well. And we just need to get, move it out into the rural areas, which is something we'd like to see, but we don't have any solutions at this point. I think I'm up. I'm 1 minute over. You have 3 minutes to evacuate the room.
That might even be a little fast. So you did great.
Okay.
So, thank you so much, Erin. And I just want to say that our meeting next month is we do an annual bigger meeting. So it's about twice the length. We hold it at a larger venue. And it's on social determinants of health. And Intermountains Alliance program will be there talking. United Way will be talking about all of their programs. So I hope you'll come. We'll make sure that you get an invitation to that. Okay, we would love to have you there.
And then hopefully all of you have my cards. Take the public comment meetings, fill those out, send those to your families. We want to hear about what the issues are so we can fix them. So send any comments you might have or thoughts or resources.
Yeah, and Avery, we send out a summary of the meeting, and I can put links to all of your handouts in there as well. But what would be awesome is if you have the ability to shoot me the links to those bills that are on the Hill right now. We are a group that gets passionate about things, and so I have a feeling that some of these folks would be willing to call their legislators in support of those bills.
I forgot the one that is not commended. I forgot to mention, and I think that this will impact your group, which is caregiver compensation. So
We just were talking about it.
So right now, they have like a person who's legally required to care for somebody, a parent, cannot bill Medicaid.
In my language, they put
Spouse. Okay. Well,
we need to.
You have woes. Well, the hope was that parents would be able to be reimbursed. Yeah.
That's what you can.
So Wayne Harper is sponsoring that, and what would happen is somebody who would typically not be allowed to bill Medicaid for providing service to their significant other, and hopefully their parent. What is it?
Senate Bill 140.
140. They would be allowed to be reimbursed at the Medicaid rate. So that's really great for people who don't work and then, are already eating the costs for that care. So if your families would benefit from parents being reimbursed as a caregiver, that's somewhere that those families you're working with can really make an impact. Tell them to call Senator Harper and make that change.
We'll get that information sent out.
Sorry if this is naive, but what kind of service would a family member, like a provider?
So like I was saying, like nursing level of care, right? Like if the parent is providing those kind of like personal care or ambulatory care, activities of daily living, they typically can't reimburse for that. But if you hired a home health and they came in and did it, then that home health can be reimbursed. Families will often do it themselves because it saves them money. But that means that then they can't reimburse because the parents are not working and the Medicaid's not paying for it, and so it just kind of becomes this snowball of problems. So the bill would allow families to bill Medicaid for that.
Yeah, that sounds like a good bill. Okay, well, thank you, Avery, so much. This is exciting. We'll get all of this sent out in our summary. And yeah, of course, just remember that next time we're at the Doty Education Center at the Intermountain Healthcare main campus in Murray. And you'll be getting more information about that if you don't have it already. We hope you can join us. Breakfast is included. Should be really great on social determinants of health in children and youth with special health care needs. George, we're about to go poof. It was nice to meet you. Hope to see you again. And safe travels, everyone. If you're in this room, I think there's lots more cookies. Grab a cookie. Thanks, everyone.
I will now. Now it's because when I said it was like $5. You got me. Yeah. I was supposed to be getting her coffee anyway. I thought we were gonna go. I was like, oh, here
Your meeting has ended.